Okay, well, look, I think we'll make a start. And so my name's Tim Shaw. I'm the academic lead on the community practice in implementation science education, funded by the Cancer Institute of New South Wales, and we very much welcome you. There's a number. Afaf Girgis, who's going to be presenting, is also on the group that steers that community practice. So we hope you get value out of today, which I'm sure you will, and encourage you to join in on other community practice activities as they arise. It's great to be able to welcome Professor Afaf Girgis this morning to come and present to us. So she's going to be talking about the role of patient-reported outcomes in patient-centred care. Afaf will be familiar to many of you, and certainly is to me. We present on a number of platforms together. So Afaf's worked for more than 25 years as a behavioural scientist in cancer control and psycho-oncology. She has an outstanding record and is an active participant in many aspects of the cancer community in Australia. She has a strong commitment to translating research into clinical practice and a real track record in engagement with service providers, which has been a real feature, I think, of our community of practice. And it's encouraging to see, once again, a wide range of people coming into this webinar this morning from different types of areas, both research and service. So AFA's got more than 260 publications and more than $42.8 million in collaborative research funding. And she's run numerous trials and other events in psycho-oncology. But today, I'm coming to talk about something that I think we all find really interesting, which is this role of patient-reported outcomes in patient-centered care. Clearly, patient-reported outcomes, as Afaf will talk about, is becoming kind of one of the hot data points, I guess, if you like, in as we move forward in rollout of electronic medical records and really understanding how patients can report on the care they receive. So without further ado, I'll hand over to Afaf. Just before I do that, just on a housekeeping point, so we certainly encourage participation. Afaf's going to talk for probably around 20-25 minutes. Now, you can then ask questions after that. So we've got plenty of time for questions afterwards. You can either type your questions in as Afaf's talking and they'll appear to us and we can ask those questions to Afaf, or you'll see there's a little hand tool to put your hand up and then we can actually unmute your microphone and you can speak to us in person. So encourage you to think about questions that you can ask Afaf at the end. So we're going to hand over the presentation to Afaf now, and we'll all look forward to hearing what she has to say.
Okay, thank you, Tim. Now I'm just going to show my screen. Here we go. Show you the screen. Okay, can I just check with people that you can actually now see the PowerPoints?
We certainly can.
I'll take that as a yes.
Yeah, we can, Afaf.
Okay. All right, terrific. All right, terrific. So thank you everyone for joining in, and as Tim said, I'll talk for about 25 minutes or so and then very happy to take some questions. So firstly, what I'm going to talk about today is what are some of the clinical and system problems that need to be addressed, and what do we need to do about those? What's the role of patient-reported outcomes in supporting patient-centred care? And then I'm going to talk to you about the prompt care model, which is an integrated approach that we've developed in Southwest Sydney LHD and the Illawarra Shoalhaven LHD, and tell you a little bit about that and how it ticks some of the boxes in the patient-reported outcomes area. So firstly, what are some of the issues that need to be addressed? We know that psychosocial care is not happening routinely, despite the fact that there are very effective psychosocial interventions that are now available, that systematic reviews, etc., have identified interventions, but cancer patients and indeed caregivers still report significant and continuously unmet psychosocial and informational needs. Screening for toxicities, so screening for levels of distress and other symptoms and psychosocial outcomes, is patchy at best. It happens well in some areas, it happens very poorly or not at all in other areas. And much psychosocial morbidity, we know, is not detected by healthcare providers and remains untreated until the point where it reaches crisis stage pretty much. We also know that facilitation of GP follow-up is really important. We have a very fast-growing population of cancer survivors, which requires consideration of shared care models and self-care models for follow-up care. There is now lots of evidence around that suggests to us that GP-led models are comparable in terms of significant outcomes as oncologist model follow-up, but we still have very much a predominance of oncologist follow-up care. It really is not sustainable in the long term with the growing population of cancer survivors and workforce issues, etc. At an international level, organisations such as the National Cancer Survivorship in the UK, their initiative Vision for 2010, they talked about 5 shifts in care and support for people living with cancer and beyond, and highlighted a number of different shifts that need to be happening for us to be able to achieve optimal cancer survivorship. And I've really just put red boxes around the key themes there. We're talking about a greater focus on health and well-being. They're talking about more need for personalised care, support for self-management so that we're encouraging patients to be far more involved in self-management sort of interventions. We're talking about tailored support, which really means we have to understand what the issues are to be able to tailor the support to meet those particular issues. And also routine use of patient-reported outcome measures. So there's some of the things happening and being talked about at the international level, and there are many more examples of that. So what is the role of patient-reported outcomes in supporting patient-centred care? Well, firstly, a definition which I'm sure is not required for this audience, but just so we're all talking the same language, the PROs are essentially reports that come directly from patients about how they feel or function in relation to a health condition and its therapy without any interpretation by healthcare professionals or anyone else. So it's direct from the patient's mouth, so to speak. At an international level, there are a number of different movements to come up with outcome measures, an agreement about outcome measures that really matter to patients. And a key organisation that's leading that work is ICHOM, which is the International Consortium of Health Outcome Measurement. And they're doing quite a bit of work in this area, not just in cancer, but across a whole lot of different outcome measures to agree and identify a set of outcome measures that are critical for the different types of health conditions that could then be measured by different organisations, which you can imagine would encourage benchmarking, comparison of data from different groups, etc. So it's to be highly commended. Many of you would have heard about PROMISE, which is the development of patient-reported outcome tool sets, which can be used in research as well as practice, and people can get on the website and find out more about that. This is still, a lot of money has been put into this program of work, and it's still developing. And in terms of what's the effectiveness of using patient-reported outcome measures routinely, a review that was conducted by or led by Jack Chen a few years ago now, reported in 2013, really showed strong support for well-implemented PRO assessments, so really well-integrated assessments, and showing that if they're done routinely, they can improve patient-provider communication and patient satisfaction. And the review also suggested that there was growing evidence that they improve the monitoring of treatment response and detection of unrecognised problems. Now, there's still more work to be done in this area, but there is sufficient evidence that's accumulated now to suggest that routinely collected PROs can improve outcomes that are important. At an international level, there are a number of different systems that are about, and I'm just really flashing on the screen a few that, you know, I've come across and that are around. This is not by any means a comprehensive set, but we know that across the world, groups are working in this space, in the UK, in the US, in Canada, and in the Netherlands, for example. Groups such as the Mayo Clinic have published position statements about the use of patient-reported outcomes at health institutions. And I will quote a little bit from this paper, and if people would like a copy of this paper, let me know, and I can put it up on the website or send it to Candace to circulate. But it provides some interesting details, I suppose, about what the Mayo Clinic perceived as important criteria for adopting patient-reported information at the health institution level. In Australia, the Agency for Clinical Innovation, the ACI, has led the work in developing patient-reported outcomes for use in a number of different health areas, and there are some pilot studies going on in that space at the moment. So that is an area where we need to watch this space as well. So there's a lot of work happening in this space at an international level. In Australia, though, there are currently no integrated PRO systems which are adopted as part of routine care. There's been a number of research studies, including work that was done in Newcastle some years ago now, you know, more than a decade ago now, using touchscreen computers and patient-reported outcomes being fed back to clinicians, etc. And there's work that was done in Melbourne and other areas as well. But there is nothing yet that's adopted as part of routine care. So I wanted to talk a little bit about the prompt care model which we've been developing, which is a very integrated approach. And prompt care is an acronym that stands for Patient-Reported Outcome Measures for Personalised Treatment and Care. It's an initiative that we're undertaking with funding by the Cancer Institute New South Wales and the Bupa Health Foundation, who are really supporting this program of work into integrating the routine collection of patient-reported outcomes to inform care. It's a collaborative initiative with, as I said early on, South West Sydney Local Health District, the Illawarra Shoalhaven Local Health District, and also the Cancer Institute New South Wales. And this is not a comprehensive list of the people involved, but it's really who the key players are in the program. So it really is a very collaborative initiative. The aim of the Prompt Care program is to develop and implement an integrated e-health platform, and the key term here is that it's integrated, to enable cancer survivors to achieve and maintain improved health and well-being and better cancer outcomes. And we did publish an overview of this program in Health Forum just in July this year, if people are interested in reading a little bit about what prompted the development of this program and the overview of the program. So going back to that Eaton paper from the Mayo Clinic that I mentioned before, they highlighted some of the practical considerations that need to be on the table for implementing PROs into clinical practice. And these include thought about what's the purpose of the data collection, what are the system design considerations, how will the data collection occur, what PRO instruments will be used, who will review the data and when, and finally, how can the scores be interpreted easily and made clinically relevant? What will actually be done with the collected data? And I thought this was a nice framework for then walking through and telling you a bit about the Prompt Care program and how we've aimed to address each of these particular practical considerations. So firstly, what is the purpose of data collection? We saw very much as the importance of the patient-reported outcomes feeding into supporting self-management, real-time clinical care, as well as informing research and gathering research-relevant data. So 3 major purposes of the data collection. The system design issues. This is a very big consideration when developing patient-reported outcome measures. One of the key things for our group was to ensure that whatever system we were developing, particularly as we were working with the Cancer Institute, and they wanted to be sure that this would be a program of work or an e-health system that could be adopted by other cancer centres, not just the one that we're developing it in. We wanted to ensure that we had cross-local health district governance to facilitate future uptake. And so we've got quite a comprehensive governance set up where we've got a steering group, we've got clinical advisory group with subgroups that make decisions about the various clinical issues involved in the program, as well as a technical advisory group which dealt with all of the issues relating to the IT work required to develop the program, and an evaluation advisory group. And each of those groups has input from across a number of LHDs. In particular, the technical advisory group, because we were thinking about what is the system that we're going to set this up in, we wanted a comprehensive technical advisory group that included people with the IT know-how, as well as from the information technology sections of the local health districts that we were involved in, as well as the Cancer Institute New South Wales. Now, we also consulted with an external consultant, Ashley Ma, from Didimo Designs, who was brought in because of his expertise in this particular space, and Andrew Miller from Illawarra Shoalhaven led the IT work in this space as well. So it was really important to bring the right people to the table to ensure that the technical issues were dealt with appropriately, and that the system design issues were going to mean that this is a system that could work elsewhere, not just in our particular hospitals. So moving on to how and when the data will be collected, and also what instruments will be used. This is really quite critical. For our own purposes, we went with electronic data collection for a number of different reasons, mostly because it could be collected and analysed in real time and fed back to the clinical team. I know a number of groups are using paper pen versions. The only issue with that is either someone has to interpret it on the spot, or you don't get the real-time feedback. So this is a major consideration for different groups who are thinking about adopting PROs and what is feasible within their own setting. Although I have to say, collection of PROs is important, and if you have to start with paper pen, that's a good start. So for our particular program of work, we are collecting patient-reported outcomes across the cancer journey, so pretty much from the time of diagnosis into very long-term survivorship, or if someone reaches the end of life. We're not seeing this as a one-off data collection. This happens at the clinic during treatment, and from home via the internet when they're in the post-treatment follow-up phase. And as I said, electronically, either using iPads or a computer. So which PROs will be used? This is really important, and I guess, you know, one of those things where you have to consider the patient burden, but also what's the importance of the data that you're collecting. And again, referring back to the properties of a good PRO from that Eaton paper that I referred to earlier, that it be simple, it be brief, informed by patients, very importantly, that you can trust that the data that you're collecting is reliable and valid, and also responsive to change, so that if you implement an intervention, you can detect whether there's been a change post-intervention. It's really important that the PROs are easily scored and interpreted, and that there is, a real clinical action that can come from whatever the score is that you get from that PRO. So again, keeping those particular criteria in mind, we did a very comprehensive review of the literature, and we took a number of different measures to the clinical advisory group, which was 40 plus individuals across different types of oncology, social work, various allied health, etc., and nursing, and asked them to look at the various measures that we had brought forward to them and decide what are the really important issues that will drive their clinical care. The four issues that came up were distress, symptoms, supportive care, and also quality of life came up as well. But when we actually did an item list and looked at all the items together, we found that the quality of life measure that we had selected was not adding any new information to what was already being collected through these three measures. So in the end, the clinical advisory group suggested that we drop that particular measure. So what we've got in the pilot is the distress thermometer, which is known to many people, with its checklist, and whatever items were in the quality of life measure that weren't in these measures, we actually included the individual items as part of the checklist. For symptoms, we went with the Edmonton Symptom Assessment Scale, and for supportive care needs, we went for the very brief screening tool, which is 9 items. One of the other main criteria for us selecting PROs was that there was no cost attached to using the particular PROs, which at that time excluded using the HADS, for example. Future adaptations, we will be considering future adaptations, including other potential toxicities, whether there were any survivor-specific measures that we need to include down the track. And of course, the system is very amenable to being adapted to include collection of data from people of non-English speaking backgrounds. So the survey appears very simply as you can see on the screen there, various different forms of presentation of the questions, but very simple, touching the screen where it is or clicking with your mouse to, answer a question, for example, or slide the thermometer up to where it needs to go for the distress thermometer. So we tried to keep the presentation of the questions very simple for ease for the patient to complete it. And we've had very good feedback about that to date. So very, very important. What happens when you collect the data? Someone has to review it. At what points does that happen, and who does that happen by? For our system, we've got for patients who are on treatment, the prompt care summary and longitudinal reports, which I'll show you in a moment, are available in real time to the clinical team. So the patient sits in the waiting room, they complete the assessment. By the time they've gone in to see their clinician, they can open up the report. In the oncology information system, which we use at these two particular hospitals, which is Mosaic. In other systems, there's ARIA, CHARM, I think, and there might be one or two others. The report is accessible by all the care team members, and we hope that this will support continuity of care. But the critical thing here, and what makes this system different to others, is that the reports appear within the oncology information system, as do other reports like pathology reports, various drugs being used, etc. And I think this is a development beyond other systems which have been standalone and hence not routinely integrated into routine care. So accessing the reports while the clinician is sitting there as the patient comes in, they can look up their mosaic report for other sorts of things that have happened since they last saw them. They click on reports. Prompt care will come up as the cross-sectional report or the longitudinal report. They click on which one they would like to see. They can either print it, but what we recommend is that they see it on the screen. So they just click on that and it appears on their screen, as do the other sorts of reports that they're looking at. I'll show you the reports in a moment. For patients who are in follow-up, who are off treatment, who may not be coming into the cancer centre very regularly, if they're completing the assessment from home and some of their responses suggest that they're higher than the threshold that's been predetermined, then an email will go to the cancer centre for them to review that patient's report, and based on what they think the report suggests, they can either call the patient back in early or contact them just to talk them through some of the issues, or suggest they go to their GP, for example, depending on what the issue of concern is. So the important thing is here for patients not to feel like they're not in contact with the system anymore. There is an opportunity for rapid re-access to the cancer services if their patient-reported outcomes suggest that that is warranted. So if the PROs are above a predetermined threshold, that the second consecutive assessment, and this was something the clinical advisory group talked about and came to as a decision, and that means approximately 2 to 3 weeks apart for patients that are on treatment, or about a month apart for patients that are in follow-up, at least in the pilot. Two things will happen. The patient will receive an email with their self-management information, but also recommending discussion with their GP and or the cancer centre. And this is the text of what would part of the email that would come to them, suggesting that these issues have been raised previously. Please consider discussing them with your GP or a member of the care team if you've got an upcoming appointment. The second thing that will happen is the cancer centre receives an email to review the patient's report and follow up as appropriate. We want to support shared survivorship care, and this happens through communications with the GP right from the start of treatment into long-term survivorship via treatment summaries and care plans. GPs, as people would be aware, often feel left out of the picture once someone's diagnosed with cancer, and then the patient turns up at some stage down the track and has various sorts of issues, and the GP is not really aware of what treatment they've had, etc. So this is really intended to be a regular communication with the GP. The treatment summary that's been developed, which will be used at Liverpool Hospital as part of routine care, includes information about what kind of treatment the person has had, what sort of support services they've accessed, etc. And on the back side of that, there are, depending on the cancer type, so this is for prostate cancer, what are some of the common problems that the patient might experience, and what are some of the follow-up tests and appointments that the GP may well be involved in assisting with in terms of follow-up tests, etc. Again, this is not a one-off end of treatment summary, but every time something new happens to the patient, or a different treatment or additional drugs, for example, are being prescribed, the GP would get an updated treatment summary so that they're kept in the loop and they know what has happened next to the patient. Finally, talking about how can scores be interpreted easily and made clinically relevant, and this is really quite important as well, what will actually be done with that collected data. So for our prompt care program, which the reports that appear in Mosaic, firstly there's a single date report. So if I've completed my assessment today, this is what will appear of my scores from today's assessment. You'll see here we tried to keep it at 1 page, and this, probably 4 or 5 iterations of this went to the clinical advisory group before this was decided on as the format. You can see that the red are things that you draw attention to quite quickly because they're the issues that are above threshold. They're the ones to pay attention to if you have limited time. And up the top here, taking into account all of the different measures, so the distress thermometer and checklist, the ESAS and the supportive care needs, a summary of all of that is presented in the yellow box up here by domains. So the domains being emotional, physical, functional domains, and recommendations about what actions would be appropriate to take, either in terms of direct care or referrals. And these are based on a range of algorithms that have been developed to support this sort of decision tree, I guess. As well as getting access to the report of today, the clinicians or the other staff from the team also have access to a longitudinal report. So they can look and see what have been issues that have been a concern for the patient over time, or what have appeared as new issues, what were issues and are now resolved, etc., to inform their ongoing care of the patient. So as well as real-time clinical care, we are also using the patient-reported data to inform patient self-management. So at the end of the survey, a message will come up saying, we'll send you a website link to your nominated email address to help you with resources that can help you with self-managing some of the issues that you've identified. There will be 6 pages that appear on the EviQ site, which is supported by the Cancer Institute New South Wales. And depending on whether someone identifies any physical concerns across any of the surveys, they'll get a link to the physical wellbeing. If they don't, then they won't. So only the pages that have any issues that were above the threshold will appear, and this is really to reduce information overload. When they open up a page, so for example, if they got the physical wellbeing issues, they will get a page that looks like this, where they can then click on the particular items that they would like to read more about, and it takes them straight to that site. Anything that appears on this page has been reviewed by the Cancer Institute New South Wales and gets the green light, I guess, for a supported patient-reported measure. Which really means that to avoid people going to sites that really don't have very reputable information, this is a one-stop shop for patients across the various domains that we're collecting information on. Over time, we will look at increased sophistication in self-management resources, including, various access to webinars, higher level information, links to other programs like the Enrich program, for example, physical activity and nutrition, linking to community programs, etc. So the level of sophistication in the self-management resources can increase as those become available. So just the last few slides, where are we up to with research? So we're looking at pilot testing at the moment, so we're in phase 1 at the moment, about to go into phase 2. So phase 1 is really testing the functionality of the system, accuracy and completeness of data, feasibility within the clinic setting, acceptability to both the patients and to the care team, and also listening to audio tapes of the consultations to determine how that feedback is being used within that consultation. And this will help us determine, for example, whether we need to be training clinicians in how to use the system, whether we need to give more information to patients about being proactive about discussing their reports, for example. For phase 2, we will tweak the system as required and test in 200 patients in 3 clinics. So the phase 1 pilot at the moment, which we've been collecting data from the Illawarra region at the moment, and we're about to go live in Liverpool. So as of today, we've got 22 patients who've been through the system, and there's been very good initial response from patients and clinicians about the utility. Some of the patient feedback has been, about the survey, whether it captured their main concerns. Yes, physical, emotional, even sexual, some of the issues that don't get asked about very often. This is a good way of collecting information about those issues. How did you find completing the survey? It makes you think about issues that you weren't previously prompted to think about. So hopefully, again, capturing some of those issues that perhaps weren't top of mind when the patient came to the clinic. And as I said, we are in the process of collecting this information, so more data will be available in the next little while. Into the future, this kind of system and patient-reported outcome systems that are established as part of routine care more generally allow for ongoing collection of research quality data, which can be used over time to identify gaps in care. In our context, to collect long-term survivorship issues, which perhaps not as well known about, and provide research quality outcome and clinical data for clinical trials, perhaps over time reducing the burden on patients where if data is collected as part of routine care, they may not need to complete a whole pile of other surveys if they're needing to know about the same information we're collecting. We will be looking in the future into integrating the system into other systems other than Mosaic. We need to test it in Mosaic fully first and then see what needs to change to make it adaptable, for example, to ARIA and other sorts of systems. And of course, a very high priority is to include future adaptations, which will mean, what language do you want to complete this in might be the first screen that you get, and then you can complete the system in whatever language. And we know that there are lots of surveys out there already that have been translated and are validated in the different languages. And one of the priorities for the Cancer Institute is to ultimately get to a point where there's a statewide rollout of the system and it's made available to other cancer centres to use as well. So just a few key learnings to date. Integrating within the current hospital-based systems is possible, we have found, but it can be extremely challenging, and I think that's probably been the biggest hurdle for us to date. It's been absolutely critical for us to have engagement of people at the leadership end of the health system as well as clinicians and researchers. We have had people at all of those levels involved in developing this system, and I think that will help with its long-term sustainability. It's really important to think about multiple outcomes that are included in an evaluation of this kind of system, including patient, clinician and health system levels. And we have some of those in place and we're working to include others. And finally, we need to be thinking about what are the critical cost issues that need to be collected along the way to help lobby for an ongoing system like this to be implemented as part of routine care. So that's an overview of that work, and I would be very happy to take questions online or offline from people. Thank you for your time.
Look, thanks very much, Afaf. That was excellent. Can you hear me?
Yes, I can.
Great.
Yep.
Look, thanks very much. That was a great talk. I imagine it's a lovely example of a systematic approach to having an evidence base and applying it and taking people with you. I think it's a great example. So I encourage people to ask questions. We have one from Anne Axon that I'll ask in a moment that you were just mentioning towards the end, but I encourage other people to either put their hand up or type in a question and we'll take your response. So I guess I had a question. I think we're really in the early days at this point of actually using any kind of data in direct patient care in a way. Mosaic and those other programs are only really just getting up, and obviously EMR2 rollout, the kind of Cerner rollout that's going on at the moment. I mean, you kind
Mm.
of alluded to this, but clearly there's a challenge of how we integrate this into the workflow, so clinicians actually use it. I mean, do you have a feeling for how that's going to happen? I mean, in a busy practice, is it another layer of challenge for the clinicians, or how do you feel it's actually going to be integrated into that process of care?
Yeah, I think it's going to vary, system by system and hospital by hospital. For example, the two hospitals where we've got at the moment, one of them has a very different system of follow-up of patients where they don't necessarily see the clinician when they come in for their various treatment and so on. So what they're doing in that case is their reports are actually being reviewed by not the oncologist, but a care coordinator who's been nominated to do that. So in that particular case, the patient is still completing it. In fact, the photo that I showed on the screen is of a patient who's sitting having chemo, completing the system while she's sitting there. The report will be reviewed by the care coordinator, and if there are issues identified that require a different level of review, then they're being brought to the attention of the clinician. So in that case, the clinician is only reviewing reports if they're warranted or deemed to be warranted by someone else. So that's a different system from what will be happening at Liverpool, where the clinicians will actually be reviewing them during the appointment. Now, one of the things we're going to be keeping an eye on in the pilot is we have actually scheduled a prompt care appointment prior to the appointment so that people have got time to complete the assessment before they go into the clinic. Now, is that feasible long term? One of the things we'll have to look at is how long it takes patients to do that, whether it's affecting patient flow, and also whether it's affecting the length of the consultation. If the reports are seen to be useful and not necessarily taking more time because they're honing in on the issues of concern, then I think there's a much higher likelihood that they will be adopted as part of routine care, more so than if they're adding another layer of work, I suppose. The audio tapes that I've listened to date of consultations have actually been quite interesting. Because the clinicians have been going through the various sorts of issues that they would normally talk to the patient about, and then saying, let's have a quick look at this prompt care report. You've identified X, Y, Z, and talking through those. One of the things that I'm hoping we'll do, and I'll be talking to the clinicians about this, is how can we actually make it integrated into the appointment a little bit more, rather than, okay, we've talked about all the things we'd normally talk about, now let's have a look at this report. So I think this is still a work in progress as to how to make it routinely work in practice a little bit more.
Thanks, Afra.
But I think it will vary hospital by hospital.
And I imagine some clinicians are going to be more comfortable with others and all those variables as well. So, yeah.
Yeah, and look, the number of people that we've had involved so far have said they really like it, and it's encouraging patients to actually raise issues that they normally would say, oh no, I'm not going to talk to the oncologist about that, they're too busy. So from their perspective, I think it will be useful.
Great. Well, thanks, Afra. Look, we've got some questions from the audience now. So Anne's asking, how do you support those who have low health literacy? So not necessarily in a language, obviously in a foreign language sense, but in a literacy sense as well.
Okay. Oh, there's my dog's going crazy. Sorry. Yes, I think that's a challenge, and I think one of the things we need to do, I mean, we have kept the questions as simple as possible, but I think options to consider, and again in the pilot what we're doing is we're collecting data about who are essentially deemed not eligible because they can't complete it in English, or that they feel that they can't actually read all of this information, etc. There are options down the track for considering whether I don't know what they're called, but the programs that actually read the things out to you are a possibility, or potentially using volunteers to help people complete the assessments at the clinic, etc., are options as well. I'm not sure we have an absolutely crystal clear answer to that, but I think it is a really important issue.
Okay, thanks. Yes, I guess we're really careful you don't just capture cohorts of patients rather than a cross section of patients. Yeah.
Yeah.
Another question from Ian. So Ian's asking that he's had experience with a number of patient-reported outcome instruments, but they've largely been paper and pen. He has two aspects to his question. So obviously, the first one is around you're putting this now into an electronic format. Did that require approval from the instrument's designers or copyright holders? Were there any issues with that? And then secondly, I guess, because you've gone electronic, does that in itself interact almost like a computer literacy question around patients feeling comfortable with electronic rather than paper and pen?
Okay, so I'll deal with the electronic one first. So we did some research many years ago back in Newcastle, which looked at, this older cohort, which is largely, cancer patients are generally older, and their level of comfort and acceptability of completing assessments on screen. And it was a highly acceptable measure. And certainly with the system that we've developed with the prompt care, it's been very easy. We've had a patient in his mid-80s who's completed the system. I think once patients are shown what to do, generally speaking, they are very comfortable with doing it. So, and I think so many more people now have access to computers and iPads and so on. So generally speaking, that has not been a concern. It's been highly acceptable. One of the questions we're asking in the pilot is the extent to which people felt comfortable completing it on either a computer or an iPad compared to paper pen. So we will also have that information to put at the table. In terms of copyright, etc., the selection of the measures was also based on their accessibility for free. So all of the surveys that we have used, there has been no issue with that at all. But that is an important consideration. I think people need to do their homework before they jump in and add measures to be sure that they can use them in that way. But it hasn't been an issue for the measures that we've used.
Thanks.
Did that answer the question?
And in fact, I'd echo comments about the computer use for the aged, and that's been our experience with practitioners as well. And certainly with my 89-year-old mother who's got chronic arthritis finds it much easier to actually use the iPad than to hold a pencil. But it should be better.
Yeah. And look, my non-English speaking mother who's 79 is constantly on her iPad and doing things, and I think people are getting more sophisticated now, or they've got a son or daughter or whoever with them at home that can help them if they're at home as well.
We've got another question here from Douglas. This is a nice question as well. So have you thought about how patient-reported outcomes can be integrated into areas like surgical management and care staff in those locations who don't necessarily identify themselves as cancer staff, so to speak, but are integral, obviously, in the care of people with cancer? I guess you're largely looking at a oncology environment at the moment, or?
We are looking at an oncology environment, certainly for the prompt care. The issue of whether this would be introduced at the point of surgery has been discussed. And in fact, when we were thinking where would we implement this, we decided that we would only, at the moment, go for medical and radiation oncology departments, largely because that's where patients were coming and then coming back on a regular basis, because we wanted this not to be a one-off screen. Look, I think there are possibilities for using patient-reported outcomes in the surgical setting, depending on the questions you ask, is probably how I'd answer that. So they need to be meaningful for that particular interaction. So if you're looking at change over time, and if you assess and identify issues of concern for the patient and you want to refer them or put systems in place to address the issues and review it again next time they come, the surgical department's not necessarily ideal for that because they may not be coming back regularly for there. But if there are patient-reported outcomes that are really important for you to know in relation to that interaction, then, I can't see a reason why you couldn't do it. And you could, in fact, send someone an email or have them phoned up before they come into their appointment, get them to complete the assessment from home so that when they come in to see their surgeon, the data is already there, the report is already there with whatever is required. But that's not a group that we targeted for the prompt care project.
Okay, well, thank you.
For the reason I've suggested.
I think that takes us to the end of the questions, unless anybody have any. Oh, we do have another one, another two. So is that top one Ian there? This is from Jane. So Jane's asking, is the data from an individual report provided to GP or just detail about referrals? Is the GP feedback as yet?
Okay, so we haven't started the GP feedback yet. So for the moment, in phase 2, which is close to starting, we are going to give the GPs, with patients' consent, of course, because this is a pilot, we're going to give them the treatment summary and the various information on the back. We haven't yet considered whether it's appropriate to give the GP the actual prompt care report. So that's something that we are asking patients in the pilot study. Would you find it helpful for your GP to have this information? We will also be asking GPs in the pilot study if it's helpful for them to have access to that patient-reported outcome information. But for the moment, we are not routinely going to be giving it to them. I guess one of the issues is how frequently a patient might be seeing their GP, and if they're only seeing them every now and then the last PRO report, prompt care report that was completed may not be timely to send. So that's one of the issues we need to consider.
Great, thanks. And
we're not taking it off the table, but it's not happening routinely as part of the project yet.
Obviously, this can be a massive. I imagine this is going to be a monster that's going to grow. It's a great project, and it's got so many layers to it. A monster in a nice way, not a monster in a bad way.
And I think that is the thing. We really are building a template at the moment, which we know that we've already got various modules to add to and build upon. But we just want to make sure the actual core of it is working properly. And is acceptable, etc. So the pilot's quite critical for that.
Great. And we got another question now from Stephen. This might be the last one. This is one more that comes in. So we've got self-reporting relies on honesty from the patient. Have you looked at assessing or excluding patients who actively avoid providing honest answers, particularly on distress indicators, e.g. the grunting farmer who says, "I'm fine"?
Oops, I think this is, sorry, my National Bandana Day alert has come up. So I think one of the things with completing assessments on computer or in that electronic format, and there's quite a bit of research that suggests that now that people are more likely to be honest with their responses because it feels a bit more anonymous to them. For example, we know that people are more likely to raise issues about sexual health and that kind of thing if they're completing the survey in that sort of format. So I'm hoping that we will end up with information that's more likely to be what people really feel, as opposed to if the doctor is asking, "Oh, how are you feeling today, mate?" "Oh, yeah, I'm all right." Whereas if they're sitting in the clinic waiting room before they go in and they're sliding the distress thermometer slide up, they might be more likely to put it where it is.
Yeah.
Yeah.
Right. So a tool for the grumpy
I,
farmer. Yes.
Yeah, a tool for the grumpy farmer, but we will ask the grumpy farmer how they felt about completing the assessments as well. So we'll be able to get that. I think I didn't answer one of the questions before about paper pen versus
No, I think that
the
was
comparison of paper.
yes.
That was all right.
I think
Okay.
that was okay. That was. I think you got the gist of that. That was great. Okay, look, I think because we're running up close to 9 and we like to keep on time, I just like to thank you, Afa. That was excellent, and it's very interesting. And we've had a number of people actually sending comments about how much they've enjoyed the webinar. And I'd like to thank Candice again, as always, in the background, who makes all these things happening and is furiously tweeting by my side. Without her, none of this would happen. Anyway.
Lovely. And look, if people have got other questions, feel free to email me. I put the email address up there, so
Oh, that's
very happy to
good.
respond to other
And
questions.
Candice is just noting that she'll send the Mayo article that you mentioned around, and
Sure.
also
Yeah.
we'll be making this presentation available on the community practice website. So if people know of other people that may find it interesting, then I certainly encourage them to pass on the URL, and we'll send that around with the it's just on the community practice website. So great. Okay, so thanks very much, Effa, and have a nice weekend.
Thank you.